Meeting of the Norfolk and Waveney Integrated Care Board. I'm Patricia Hewitt and I'll be chairing the meeting today. Can I start by apologising for the fact that I'm afraid I've got a technology glitch, and the result of that is I'm having to participate in this meeting and chair this meeting using my mobile. So that's why I haven't got my usual backdrop up, but of course I am the chair of the Norfolk and Waveney Integrated Care Board. A few housekeeping points, if I may, before we begin. This meeting is being recorded and will be available to watch on our website after the meeting. I'd like to welcome members of the public who've joined the meeting to watch it live. We'd be grateful if you can turn off your microphone and cameras during the meeting itself. There is an opportunity for members of the public watching the meeting live to ask questions about any items on the agenda or ask for clarification if they're uncertain about anything that's discussed in the meeting. And you can do this by raising your hand at the slot at the end of the meeting for questions. You can also raise questions during the meeting by emailing nwicb.contactus@nhs.net. Sorry, if the question relates to an agenda item, then this will be read out at the end of the meeting, or if we can, we'll take it during the agenda item. We'll either answer the question or defer the answer, in which case a response will be prepared in writing and sent to the requester within 7 days of the meeting. And we'll also put the answer on the ICB website. Please don't try and add questions or comments to the chat function, as we simply won't be able to answer them. Observers and board members are all asked to refrain from putting any comments in the chat function. And it's important because it's important that all comments made in the meeting are formally recorded by the minute taker. So any comments or questions should be spoken. The board meeting is a meeting of the ICB held in public. It's not a public meeting. And accordingly, any questions not relating to agenda items will be answered and displayed on the website, but will not be read out in the meeting itself. And finally, when we do get to the Q&A session or any comments, members of the public are asked to please remember that the meeting is being held in public, so we'd ask you not to share personal information or information relating to a third person when you're asking questions, because obviously we don't want to breach anybody's privacy or inadvertently break sort of information governance rules. Now, before we move into the normal business and the agenda, as everybody knows, earlier this week, the enormous report was published from the infected blood inquiry. And I'm sure that I know that every member of this board, and I'm sure everybody across the NHS in Norfolk and Waveney, would want to join the apology that was made by Amanda Pritchard, Chief Executive of NHS England, on behalf of the NHS in England. And I just wanted to quote a bit of what she said in response to the report. We owe it to all those affected by this scandal and to the thorough work of the inquiry team and those who have contributed to take the necessary time now to fully understand the report's conclusions and recommendations. However, what is already very clear is that tens of thousands of people put their trust in the care they got from the NHS over many years, and they were badly let down. This is Amanda speaking. I therefore offer my deepest and heartfelt apologies for the role the NHS played in the suffering and the loss of all those infected and affected. And as Amanda has said, on behalf really of all of us, it is essential that we reflect on the report, learn lessons, and then take action as a result. And I know that our team in the Integrated Care Board and colleagues right across the NHS in Norfolk and Waveney will be doing exactly that. Our Quality and Safety Committee, of course, will consider these issues, and we will bring them back to this board, to our full board, later in the year. And I know too that colleagues in primary care, especially in our GP-led practices, but also many in acute hospitals, will be responding to questions from patients, from families, carers, and others. And of course, we will do everything possible to support all our colleagues in responding to people's very understandable concerns or anger about this tragic situation. So, having said that on this issue of deep concern to, I think, everybody in the country, let me now, if I may, turn to the necessary formalities at the start of this meeting. So we start, if we may, with apologies. We've received apologies from Debbie Bartlett, Aliona Derrett, Dr. Hilary Byrne, Tricia Dorsey, Karen Watts, Director of Quality, is here to present Tricia's papers and assist with questions. Thank you very much, Karen, for being with us. Hein, Vanden Wildenberg, Bill Borrett and David Holt will all join the meeting shortly. They weren't able, for various reasons, to be here exactly at the beginning. Declarations of interest. Sorry, my apologies. Let me just check. Chris, have I captured all the apologies correctly?
You have, and Bill has just joined.
And Bill has just joined, thank you. The minutes of the last meeting, have colleagues had a chance to look at the draft, and are you content with those minutes? Thank you, so I will sign those as a correct record. Declarations of interest, of course, are published on our website in the usual way, but if you do have an interest that relates to an agenda item on which you want to comment, perhaps you could just draw people's attention to it. Item 4, Chair's actions. And on this occasion, as you can see in the papers, I had to take Chair's action in order to approve our 2024-25 operating plan submission, and also to authorise and sign the letter of support from the Integrated Care Board to our acute colleagues for the business case submission for the electronic patient record that is so badly needed within our 3 acutes and is such an important strategic priority. And I did that because the meeting in private at which we discussed it of the board, although there were a large number of us present, wasn't quite quorate at the critical point. Karen, is there anything you need to add to that?
No, that's fine, thank you.
Fine, no, any questions on that? Don't think so. On the action log, I think the first item is clear. We'll roll that up in a future wider piece of work. But on freedom to speak up, Karen, or would it be, do you want to just give us an update?
Yes, I don't think we're able to update on that item at the moment because Tricia Dorsey was going to update at the meeting, and because she's been unable to attend, she's been unable to update me for that. So perhaps we can push that to the next meeting.
Okay, so that remains an open issue. Any comment or question on the action log? Thank you. Okay, well, that brings us to the report from Tracy and myself. And I just wanted to add, if I may, before coming to Tracy, on Monday, I had the great pleasure of visiting the Health Inclusion Hub, the Health Inclusion Service in the centre of Norwich. This is a really important service. It relates directly to the strategy on health inequalities that I will come back to. And I was talking to one of our senior nurse practitioner colleagues, one of our primary care leaders, Tracy Williams, about the work that's being done to support homeless people, but also the work to support refugees and asylum seekers. And it's a wonderful collaboration between primary care, this integrated care board, the adult social care colleagues in Norfolk County Council, and the voluntary sector. So it was a very, very useful visit and a very good example of exactly the kind of integrated and proactive care that we are seeking to extend to all of our most vulnerable and at-risk communities. And I followed that by joining Frankie Swords, our medical director, at the Norfolk and Norwich, where I'm delighted to say we'd been invited by the lead consultant the consultant who leads the consultants committee at the Norfolk and Norwich, where we had a very, very useful and interesting discussion around the role of the Integrated Care Board and the opportunities presented by through the wider integrated care system. It was a very, very useful and interesting discussion. But can I hand over at this point to Tracy to elaborate on, and then we'll take questions on the report. Tracy.
Thank you very much, Patricia. So I will take the report as read, but there's a few things that I would just like to pick out. Firstly, on the system finances, as you all know, the board challenged us in the last financial year to break even, live within our means, and prioritise our resource. And I'm very pleased to say that we did that. So I'd like to record great thanks to everybody in the system for their parts that they played. Looking forward to the financial year that we are coming in, we are still in the planning round, so I can't give you final figures. We expect to have our planning signed off hopefully in the middle of June, which is later than normal, but the planning guidance this year came out later than normal as well. As it stands, we have £176 million of efficiencies in our current plan, and we are expected to go a little further. So that gives an idea of the scale in which we are changing and transforming at Norfolk and Waveney to make the best use of the Norfolk pound. We're also looking at the medium and long-term financial plan and thinking about the two new build hospitals that we will have on our patch. The growth, of course, and our demographic growth and our ageing population, and how we will use our finances differently. So there is an enormous amount of work going on right across the system, which will continue over the next 5 to 6 years in looking at how we transform care, but also how we best spend our money. I also wanted to just talk about the Talking Therapies contract, which we have recently commissioned again. I'm really pleased to see that we've doubled the number of locations. I know it's really important to people to be able to access services locally around mental health. So I'm really pleased that we've been able to listen to our service users and change that contract. And I think hopefully that will be a great success and a great partnership between the NHS and the voluntary sector in the coming years. I also wanted to mention dentistry because we know how difficult it is for people to access NHS dentistry, and really the state of affairs that we inherited just over a year ago as an integrated care board. Very pleased with the short-term dental plan, which we put forward last September. And the 2.3 million we invested specifically over 2 areas. So first of all, the emergency care, which we are now able to support an additional 1,800 urgent care appointments for people across Norfolk and Waveney each month. But also on the unit of dental activities, so the amount of money we pay dentists, we have increased that. So our minimum amount is above the minimum amount set by government, and we're looking at all sorts of different ways that we can increase our dentistry provision and attract dentists. And I'm really pleased to see the long-term plan now, which is over 5 years. In the coming year, we'll be investing an additional 7 million, and we're looking at things like retention of our dentists, attraction of new dentists, better access for children and young people, and also a lot more around self-management and oral health as well. So more details to come on that. And then finally, I'd just like to raise the engagement work we're doing around Benjamin Court, which is up in Cromer. We do have a live engagement exercise. Board members will remember that some of the campaigners kindly came to our board meeting in Cromer some months ago. That engagement exercise is available on our website. It's also referenced within the papers, and it now runs until the 4th of June. So we really would like to get out to networks and encourage people to be involved in that. Thank you, Chair.
Thank you very much indeed, Tracy. Questions, please, or comments on our report? Bill.
Thank you. I just wanted to endorse everything that Tracy said about the dental strategy. I think this is really very positive, and it's really nice to see progress being made in such short shift. And I think I'd just like to congratulate everybody who's involved with it. And I know we're not there yet, and I look forward to where we're going as well. So I just want to endorse what Tracy said.
Indeed. Thank you very much, Bill. Caroline.
Just again, would like to endorse what Tracy said around mental health and the talking therapies contract. Really great to see the expansion of community services and community bases, and fabulous to see the wider partnership with the voluntary sector. Really, really important going forward. So thank you very much.
Good. Thanks, Caroline. Any other comments or questions? Don't think so. Right. So we're content, I think, to note that report. Thank you very much. Now that brings us to our first really major substantive item for this agenda, which of course is the health inequality strategy. Really, really important part of our core purpose for being here as an integrated care board for the NHS, but also to our wider shared purpose as part of the wider integrated care system. So I'm going to hand over to Mark, to Tracy Williams, whom I referred to earlier on, and to Stuart Lyons, Director of Public Health at Norfolk County Council. So Mark, will you take us into this, please?
I will do indeed. Thank you very much indeed, Patricia. And I'm delighted to bring what I think is this very important paper today, which outlines and to present the Norfolk and Waveney ICS Health Inequality Strategic Framework for Action. So not just a strategy that sits on a shelf. Our aim is this is a framework for action. Hopefully, I'm sure you'll have read all the detail provided, but we're really, really pleased to bring this today. Thank you. I should also say to Patricia and Bill, who contributed to the forward for this important strategy for us. So thank you for doing that. A phrase that many people are bored of hearing me say is that everybody needs something and some people need more. And I think this strategy is our Norfolk and Waveney approach, and outlines our system approach to address some of those challenges. And I think hopefully you will see from the document that there's some real crispy, finite things that we want to be doing as a part of this work to really make a difference. And that's so important to do. Final point I'd like to say before I hand over to Tracy is just how grateful I am actually to the many people, many stakeholders right across Norfolk and Waveney who've contributed to this. This isn't us as an ICB or just it's not our document, it's everyone's document. And I was really pleased to see the engagement, the enthusiasm that people demonstrated to really contribute to hopefully make this a far better strategy and framework for action. So thank you to all of you that have done that to this point, and those who aren't on this call. But Tracy, perhaps you could just pick out a few of the key highlights. I'd be most grateful.
Happy to do so. So thank you for that introduction. So yeah, our Health Inequality Strategic Plan for Action is a 10-year strategy, and it's an ambition, one of the ambitions, our joint forward plan. It's been developed, as Mark has mentioned, following extensive engagement across our integrated care system, which has been shaped by our health inequality conversations across all sectors, including our place boards, our health and wellbeing partnerships, our voluntary sector, and most importantly, our community voices, particularly with a focus on those more quieter voices. The framework sets out 10 clear actions for the next 12 months in order that we can lay the foundations to create the conditions for success and to bring our partners collaboratively together under a common shared vision and a set of priority areas. We know to address health inequalities, we need those strong foundations because we want to make a difference within 3, 5, and most importantly, the 10 years that we have this framework in place for. At the heart of the framework is all of our residents and communities that experiences differences in health outcomes, which is often based on where they live, where they grow, and where they work and where they play, and which we know often are unfair, avoidable, and which we must act as an ICS altogether to address. The ICB is tasked with leaving the healthcare inequalities building block, which is aligned to the legal duties we have to address health inequalities. And also it's a requirement of all NHS providers to fulfil an NHS statement of information, which is mandated by NHS England, which came into force last November. But we want to do this as a whole system and bring this together, and it will require a whole system response. As I said, there's 10 actions for the first year, and at the moment we have discussions underway with our integrated care partnership to support that we have clear accountability and governance to drive those actions forward. We've established that there's 3 key areas where we need to create those building blocks, which is around living and working conditions, which is around lifestyle factors, and as I'd mentioned, healthcare inequalities. And we know that the NHS within its sphere of influence recognises the contribution it makes to those other building blocks as well. It's been a real collaborative approach to develop the framework, as will the implementation. So I want to just hand over to Stuart Lyons, our Director of Public Health for Norfolk, who just wants to say a wee bit more about that.
Thank you very much, Tracy. And yeah, so to reiterate a few points that have already been made, and just to build on those, I'll keep it brief. But the important points, I think, is one, the collective nature of this and the collaboration that's run throughout. This is clearly an area that we all want to work towards making improvements on. Also, that it's a 10-year overall plan, and I think that really points to the fact that this is a sustained action that will be driven across the coming years, because we know that health inequalities are largely persistent and often intergenerational, and so these are often deeply entrenched inequalities that we need a sustained course of action to help address. And also this strategy gives I think a renewed impetus to really work together as a system. So what this does in effect is lay the framework for how we work and work together, and enable us to think and act more effectively as a system, a whole system approach to addressing these inequalities. And as Tracy has said, the building blocks or the boxes that you'll see in the paper around living and working conditions, lifestyles and healthcare inequalities all form part of this wider picture. And it's incumbent upon us to make these connect together, because they are interrelated, and also relate very clearly, I think, to prevention. Particularly around the living and working, we're thinking about those wider determinants of health, housing, employment, education, etc. And what we can do as a collective system to help address and improve health outcomes through that route. And then the lifestyle factors really points to primary prevention. That's helping people quit smoking or manage their weight or take more physical activity. And then the healthcare inequalities is around access to services and how we can work together to improve services and improve access to those people who may find it more difficult for whatever reason. Importantly, or crucially, is the relationship with place, because obviously a strategy will only be as effective as its ability to deliver real change, and that's about working with communities, supporting our communities to adopt different behaviours, but also the things that affect and influence those behaviours. So I think what this strategy does is bring this together into one coherent whole. And it also, in relation to place, we also have to recognise we have part of Suffolk in our area. Yes. And obviously we work very, very closely with our partners in Suffolk, and I know Stuart's here, to ensure that the whole system addresses these different challenges and needs. So that's my my contribution, but also to emphasise that public health is incredibly supportive of this, and we've been an active part of developing it. So that's hopefully very positive. And I'll just hand back to Tracy. I think it's Mark, sorry.
Mark was just going to kind of sum up, because we have some recommendations.
I think we've covered it, and it's outlined the paper, so thank you both. But yeah, so in summary, we're just asking ICB board members to endorse the Norfolk and Waveney Health Inequalities Strategic Framework for Action and to support the plans outlined for its implementation, and also to request that it undertakes the board self-assessment as a part of as outlined in the paper to support this work going forward. Thank you, Patricia.
Good. Mark, Tracy, Stuart, thank you very, very much. And through you, thank you to the very large number of people, including, I think, some who are actually on this call today and watching this board meeting. I have to say I was absolutely delighted when I saw this, because I think it's, if I may say so, quite often within the NHS, you know, strategies get sort of developed in, let me say, quite a bureaucratic way, and we can sometimes produce lengthy strategies that nobody really reads because they're not really very attractive to read. And this one feels to me like an absolute piece of partnership working with Norfolk County Council, but with a large number of other individuals and organisations, reflecting that wider partnership across the system. And that, of course, is why Bill and I wrote the forward together and signed it together. But I also think the whole way, in the very vivid and visual way in which it's presented, the maps, the illustrations, the highlighting of where some of our most disadvantaged communities are with the worst life expectancy, all of that really brings this alive, and I hope it will make it much more compelling as a framework for action, and not simply a strategy that is written because somebody has told us we have to have a strategy. So with that, let me bring in many other colleagues. Let's take, sorry, I'm just checking the order in which they're showing, or I'm trying to do that. Let's take Caroline, then Stuart, then Emma, then John Barber, then Bill Borrett. We'll take those 5 to start.
I'll be quick, given the number of people that want to speak. So I would concur that I think it's an excellent strategy and really well presented. So thank you so much. I guess 3 points. It's great to see the ICB doing the board self-assessment. Mark, it will be brilliant if we all did that, and just encourage that as a system. I think this is a real fantastic area we could be working collectively as a system. I know we already are. Secondly, I couldn't concur more with you around place and that being at the heart of the strategy. And certainly from our perspective as a provider, we're moving to a place-based model, and a significant part of that is recognising the role we should be playing and could be playing in reducing health inequalities in local communities. And my third question really is whether there's an opportunity for us to consider people with a serious mental illness as part of the plus group, because there's a massive level of evidence about mortality and morbidity gaps with people with SMI, and it would be great if we could include them in the plus group. That would be fantastic.
Good. Thank you, Caroline. Stuart.
So now I'm just endorsing Stuart's point that we do work closely together, and actually colleagues in Suffolk and North East Essex who are working on inequalities met with our Norfolk and Waveney colleagues to see how we could work together more broadly on that. So I think that's really positive. It's good to see the breakdown of the focus of the strategy. As you say, you've got an aspect around the wider determinants, around the lifestyles, and then particularly around the healthcare part. And that was a bit I just wanted to kind of drill into for a moment. I think sometimes that's the most challenging bit. I think we often get excited about the importance of the wider determinants of health and recognise that in the long term, these are the things that will make differences. But actually, it's also our role in delivering health and care to make sure we don't drive those inequalities any further. So I think my question or challenge is about how do we start to bring in metrics that enable us to see whether we're having an impact around that with regards to access, experience and outcomes. And I think across the country, lots of systems are going to be thinking about that. But I think if not, it makes it difficult to know, are we making that difference, especially across some of our key metrics. So I think that's the challenge that we all face, but we'd be really pleased to be part of that as well.
Great. Thank you, Stuart. Emma?
Thank you, Patricia. Can I just firstly apologise for not having my corporate background on? Someone has sent it to me, but I need a young person to help me upload it. Yeah, I just want to endorse everything that people have said beforehand. I think this is the first framework that feels like it's properly engaged the VCSE sector, and as a result we have on our new assembly structure a portfolio holder for health inequalities, which I think is going to be very beneficial and allows us to work closely. And just on a self-reflection point, it feels a bit like this is what you can get from the voluntary sector when we feel like we're part of and we can see ourselves in a framework and a strategy. So thank you for that.
Great. That's really good to hear, Emma. Thank you. And a very important step forward from which we can build in other areas of work. John.
Yeah, no, thank you, Chair. We've had a lot of people say what an excellent framework it is, so I won't dwell on it. It is an excellent framework. But Chair, you said there should be a compelling framework for action. Just want to give board some assurance it's already turning into action. I chair one of our 5 place boards, and we are trying to hardwire the objectives from this framework into what we're doing at a place level, and certainly from an acute perspective, we are also hardwiring it there. So it is already starting to turn into tangible outputs. Chair, I would just encourage us to have all our organisations sign up to do that board self-assessment on health inequalities. So important, but a brilliant framework. Well done to those that produced it.
Great, thank you. And Bill.
Yes, thank you, Chair. It's been spoken about by many that it's for the whole system and not just for the Integrated Care Board. And it accordingly, it is coming to the next meeting of the Integrated Care Partnership on the 12th of June, where I hope to get buy-in from the other parties to the ICS, local government and everybody who's been involved in producing the strategy. And it was great to hear Emma Ratzer speaking so positively about engagement with the voluntary sector as part of the development of it. I think place is going to be crucial. I think it's not really often understood by the layman what it means, but I think it's about services being about people rather than being about structures and organisations. And I hope that this is going to be the beginning of the way that we change, that we interact with people in these communities who are suffering from health inequalities. So I do endorse it, and it's great to hear everybody speaking so positively about it. So thank you very much indeed.
Good, thank you, Bill, because you've been such a champion of this work around inequalities and the left shift and so on, really from the beginning of your time as chair of the Health and Wellbeing Board, so quite some years ago. Good. Mark, is there anything you or colleagues just want to say briefly by way of response?
Absolutely. Well, firstly, thank you for the very positive contributions. We are very much aware the hard work starts now, but we do feel we're in a strong place to take this work forward. So thank you for your very positive comments. In terms of the 2 questions I think we picked up, and Tracy may want to come into, Stuart, the metrics. Absolutely, it's the hard bit. We also work with regional and national colleagues on this. We've tried to include some of those in the documentation in the framework, but there is more work to do, particularly on the health aspects as you've highlighted. But we are keen, and we do challenge ourselves regularly. What are the ones that we're going to capture? We don't want a list of 1,000, but what are the key ones going to be for us as a part of this work? And Tracy, do you want to expand on that and pick up the point about the plus groups and the SMI?
Yeah. I mean, I think our plus groups were kind of established and agreed, supporting by public health colleagues with the evidence and the population health information in respect to that. So certainly I will look to our colleagues in public health, and I'm sure Stuart's team will support that, as they have done already, about looking at those with an SMI as a plus group, so we can kind of consider that as well. So thank you, Caroline. We can certainly look to include that and just look at that evidence around that, which I know that group of individuals do have extreme and severe, multiple disadvantages. So very happy to take that one away with us. And I think in respect of the data, that access, that experience, that outcomes, we've got some programs already underway, our community voices, which is gathering some of that kind of what's people's experience of accessing healthcare. And I think certainly some really good work that Frankie's very closely involved in respect of our data hub and our populational health management. We've got a strategy in respect of that as well. So we want to monitor, have that data, have that information. So some really good things that are working alongside each other at the moment.
Good. And Stuart, anything you wanted to add?
Nothing really.
Right.
Just to say,
Thank
we're obviously
you.
going to be supporting around the
Yeah.
metrics in particular.
Great, thank you. Well, look, thank you very much again. And in terms of our decisions as a board, I take it we will unanimously endorse the Health Inequalities Strategic Framework for Action. Yep. And support its implementation by undertaking the Health Inequalities Board assessment, and we're committing to do that before the end of July. What we will also do, if everyone's content, is strongly urge all our partner organisations, their boards, to do the same thing. Everyone content with that? Good. Thank you very much indeed for that. And we now move on, really importantly, to the all-age autism strategy, and we will then look at the tricordant review report on learning disability and autism. But Karen Watts, deputising here for Tricia Dorsey and her colleagues, if I can hand over to you, Karen, for the all-age autism strategy first.
Thank you very much, Patricia, and thank you to colleagues for joining this afternoon. So today we're really pleased to bring the refreshed all-age Norfolk autism strategy for autistic people. This is for people of all ages, their parents, their carers and their families, and more importantly, those who are supporting and people who are interested in autism. And it's very much building on the previous strategy and the good work that took place in relation to that. The Norfolk Autism Partnership Board has worked really hard in setting up the reference group to co-produce this strategy, and it's been really important in terms of the engagement of seeking autistic people's views and their families to really inform what matters to them and what will make a difference. Key partners have also been involved, and this strategy also incorporates many other key strategies that are associated. There is a requirement under the Autism Act from 2009 for local areas to develop their strategies, and I'm really pleased that this one will be brought forward for the next 5 years. So the vision for the next 5 years is to ensure that Norfolk will be an autism inclusive county, to improve the understanding of autism in the public and amongst those who are providing the support. There are 6 key priorities linked to the strategy, and one is to improve understanding and inclusion of autism, improving access and education to support transitions, which is absolutely pivotal, and more importantly, for adults to support them into employment. And I mean that by meaningful employment. So what we want to do is reflecting back to our previous conversation, which was about tackling health inequalities for autistic people, making sure that we build the right support in the community and we improve support within the criminal and youth justice system, because sadly we do see people that are very vulnerable and sometimes end up placed within that system. So we're asking the board to endorse the Norfolk and Autism Partnership Board's all-age Norfolk strategy, and for us to work very closely with the partnership to develop a delivery plan. And I'm very happy to open up to any questions. The detail of the strategy is contained within the papers. It's a really lovely read, I have to say. It is a really lovely read, and I'm looking forward to translating that into action. And I'm sure my colleagues may wish to add some comments at this point. Thank you.
Thank you, Karen. Yes, or perhaps what we could do is, should we take some questions and comments from the board, and then you might like to introduce your colleagues and they can add some comments and help with questions at that point. Would that be sensible?
Yes, thank you.
Certainly welcome to them. Right, Hein.
Yeah, thank you very much, Karen and colleagues. I very much enjoyed the read too, Karen, so well done to you and many colleagues. If I make a link to the previous agenda item, there was a big importance around action oriented and delivery. And I know the delivery plan will come in a few months' time, but I think it would be good for us as a board later on this year to hear how that delivery plan is shaping up, see where you need help, because I think we're all sort of standing behind the cause. Thank you.
Thank you very much, Hein. And I think next, yes, Emma, please, and then David.
Thank you. Karen, I wonder whether it would be useful just to have an offline conversation, because autism is one of the strands that sometimes gets discussed at the assembly level about whether we need to have an individual portfolio holder just for that, which spans across all the services. Not sure we're quite there yet, but it would be useful just to see if that's worthwhile from an ICB point of view. So be interested to have that conversation.
Absolutely, Emma. Thank you.
Great, thanks, Emma. David.
Yeah, could I just ask about diagnosis here? Because patently we have a strategy here, but in order to sort of people to benefit from it, they need to be diagnosed. And I'm just wondering what the sort of the wait time is at the moment around that, because in the past that's been one of the issues about getting people onto or embraced by these strategies, is the time it then takes to diagnose them and get them into the system.
I think it's fair to say this remains quite a challenge across the country, doesn't it? Apologies, Karen. Let me come back to you and your colleagues.
Absolutely. So if I may start, David, there are huge capacity challenges and a rising demand for diagnostic assessments for individuals with neurodivergence. And we are looking very much at working with our providers to streamline the pathways to try and increase the productivity. There is pre-diagnostic support in place and an information pack to support parents and young people whilst they're waiting. We appreciate that's far from ideal, but it's an important step to have in place so people feel they are being communicated with. And we're currently in the procurement phase of a provider framework where we can flow any additional slippage or waiting list initiative funding to increase the capacity. The CYP System Collaborative has recognised that this is a priority area, and this is an area they are very much focusing with. And this builds in quite nicely to wanting to work with our local authority, education and health, and looping back into Emma around voluntary sector, because looking very much at early identification and support to reduce that demand at the end is one of the most important things. But we recognise this is a very long-term piece of work. It's issues that we have in common with many other systems, but we are taking it very seriously, and having it therefore as a focus for the CYP System Collaborative is pivotal. I hope that helps. Thank you.
Very much so. Thank you, Karen. CYP, children and young people, just in case we do all speak in acronyms and it can make life difficult. Karen, do either of your colleagues, do you want to just, I don't know if they want to add any comments at this stage?
Yes.
Thank you. Yes, I'm Karen Dewars and I'm the Strategic Business Lead for Autism in Adult Social Services at Norfolk County Council. So my colleague Tracy and I are here on behalf of the Norfolk Autism Partnership Board to present the strategy just for this item. There were just a couple of other points I would like to make, if that's okay, in addition to what Karen brilliantly set out just now. So just to make the point that as well as the full version and the summary version that we shared in advance of this meeting, we are planning that there will be an easy read version and other formats as well, based on what autistic people say we need. So we're thinking that's likely to be an animation, for example, but that will, we'll work with our autism strategy reference group to decide on the different formats that the strategy should be in. I just wanted to highlight as well that because the Norfolk Autism Partnership Board reports into the Health and Wellbeing Board, we will be taking the strategy there on the 12th of June, and we'll be asking the Health and Wellbeing Board to adopt the strategy on behalf of all partner organisations. But as Karen said, what we're asking partner organisations to do is to endorse the strategy, to agree to work with the Norfolk Autism Partnership Board to create the delivery plan. And we're also asking that, assuming that is agreed, whether it would be okay to add the ICB's logo to the strategy before we publish it, because we'd like to add all of the logos on to show all of the organisations that are involved.
Good. Thank you very much indeed, Karen and Tracy. And once we've endorsed the strategy, I'm sure there'll be no problem at all about adding our logo. I should think we would want it there. Let me come to Stuart Keeble and Cathy.
Thank you. It's just following up on David's question, and clearly that's one important aspect. But I think one of the other things the strategy makes very clear is that what we need is an inclusive society. And actually, capacity is always going to be a challenge for this space. And actually, the more inclusive our workplaces are, our education settings are, actually for some people, they may not need a diagnosis as they're able to actually live their true selves. So I think rightly, we focus a lot on the diagnosis, but actually there is still far more work we need to do around actually strengthening and supporting society to be more inclusive, because I think that's the only way we're ever actually going to be able to resolve this more broadly. Now, that's a big issue, but I think it's just something we need to always remind ourselves of.
Rather than always seeking the medical label, I think. Yeah, interesting point. Thank you, Stuart. Cathy.
Thanks. Mine follows on from Stuart's, actually, because I was just wondering about employers. You know, I was struck by the number of people who aren't at work, and you know, employers are always doing as much as they, you know, seeking to do as much as they can now to be as inclusive as possible. And I just wondered, is it because there aren't the links currently there with employers, or are there trailblazers out there who are really doing something? And you know, how can we do more as employers to close this gap? Thanks.
And perhaps before, hopefully somebody will respond to that, but it does seem to me that we could be doing more collectively as the NHS, but also in social care, to make those more welcoming and inclusive environments for people who are neurodivergent. There is some really good practice there, but clearly looking at this level of non-employment, an awful lot more could be done. So Karen, don't know whether you or other colleagues would like to comment on that.
I think it's absolute. Oh, sorry, I'll let Karen go.
Well, no, I was going to see if Tracy wanted to come in because she hasn't had the opportunity to introduce herself and speak, and so I thought she might want to pick up that point. Is that okay, Tracy?
Yeah, absolutely fine. Thank you, Karen. So hello, everybody. My name is Tracy Walton. I'm an Autism Commissioning Manager for the Norfolk Waveney ICB and Norfolk County Council, but employed by Norfolk County Council. Just to say that I do think that you know, addressing the issues around employment will come through the delivery plan. So working with partners, organisations to identify what they will do to change how we work with autistic people and what support we provide to them. So I do think it's a whole system approach and something that we all need to work collectively together to achieve better outcomes for autistic people. Is there anything you wanted to add to that, Karen, before I hand back?
No, that's fine. Thank you.
Patricia, you're muted.
My apologies. I was. It's the joy of working for the mobile. Apologies for that. Thank you very much, Tracy, Karen, and Karen. I think that's been a great presentation, really useful discussion. So is the board content to endorse the refreshed Norfolk All-Age Autism Strategy for 24 to 29? I think that's unanimous. And we will agree, of course, that we'll work with the Norfolk Autism Partnership Board to develop the delivery plan. Is that also agreed? Yeah, thank you very much indeed. Good. So we'll move on to our next agenda item, which is the Learning Disability and Autism Review that Tricordant has carried out on our behalf. Again, Karen Watts, you're going to introduce this. And I think you also have a colleague with you.
I do, who
Lovely,
will be able to provide additional detail if required. So thank you very much, Patricia. I'm going to assume the paper has been read. It's very detailed and it's very, very clear. So just to revise the purpose of the paper, in the summer of 2022, Norfolk County Council and the Norfolk and Waveney ICB commissioned a review, an external review from Tricordant, to explore the outcomes for people with learning disabilities and or autism in Norfolk, and what could be improved upon through the planning and the commissioning and the provision of our learning disability and autism services. So the remit was very, very clear, and there were 2 stages to this review. In stage 1, it was very much reviewing what was in place between the learning disability and autism commissioning and governance. And I think one of the real findings was that incrementally and unintentionally over the last decade, and this is quite difficult to say really, they're included, that LD&A, or learning disability and autism, was not necessarily seen as a priority and no overall funding. And I think that was set in the backdrop of both organisations probably going through many changes at the time. So I think it was absolutely unintentional. The summary of stage 2 findings was really looking for a different way of working together more cohesively as a partnership in terms of the County Council and the ICB. And with co-production with experts by experience, the report really spent quite a long time in identifying what the commissioning in Norfolk really looked like. And they identified that it was fragmented, that we spent very large proportion of funding on a small number of people where the outcomes were not the best, and a strategic reset was needed in terms of governance. The Tricordant partners it reviewed 8 individual work streams and which each area was evaluated, and the findings informed the final recommendations. In terms of the options, there were 3 main options, which was do nothing, which I believe was not an option as such, move to a single joint commissioning system, and number 3, a strategic reset, which is really what is recommended within the paper. So the details are really set out quite clearly in a detailed report. So I think one of the most important ones is to declare an improvement for learning disability and autism services as a priority within the next joint forward plan. To establish an LD&A executive board to oversee across Norfolk County Council and the ICB, to ensure we have a senior accountable ICB officer in place to have oversight of this, agree, revise and improve commissioning structures for both NCC and ICB, and that's to be guided by our commissioning development plan, and the ICB to take back accountability for commissioning specialist healthcare services. And this is based around the service redesign guided by the building of the right support and national service model. So ensure the transfer of specialised healthcare services to us is revenue neutral through the funding transfer agreement or reviewing the LD&A elements of the Better Care Fund. I think number 7 is quite clear in terms of what it's recommending in developing and implementing a funding agreement, policies and procedures. That is really important. So that we can agree a joint service for individual package costs on the packages that are meaningful and actually supports that individual's needs. So to implement a programme of business support, business processes improvement, including a shared strategic report, and to design and implement a joint upstream learning disability and autism quality response for the oversight and improvement across health and care. So really it's about establishing a strategic workforce planning and delivery steering group. And I think the conclusion from the Tricordant report was that this will put our system, our collective system, in a much stronger position to move a much more robust and aligned commissioning position. And it will help create better conditions for market engagement and for specialist healthcare providers, which we need in the wider care market. So I thank you for the time to listen to this, but I think it was an important report and we'll be happy to take any questions on it.
Great. Thank you very much indeed, Karen, and thanks to you and to Joe and clearly many others who've been working on this hugely important piece of work. Are there particular questions or comments from people? Bill?
Yes, I just wanted to say from my point of view at Norfolk County Council that I support this reset. I think here we are focusing again, as we mentioned in the earlier report, about the delivery and the people who we serve. And I think that the proposal here is the best way that we, moving forward, that we can make a real difference in this area. So it's been really good to reach agreement between the different organisations that haven't got in the way of designing the right sort of service to support everyone.
Indeed. Thank you. Thank you, Bill. Are there other comments or questions? I'm not seeing any hands going up. Look, I think, you know, the quality and importance of the work really speak for themselves, don't they? And again, I think it's really good to see this very strong partnership between Norfolk County Council and the ICB, and the co-production approach that's been employed in doing this work, and the honesty, you know, just the openness about, for whatever reason, and we can understand reasons, it hasn't been good enough in the past, and we're now tackling it and clearly determined to improve it, even if that takes some time. So can we all please, well, not just accept the report, but in particular, accept the recommendations, approve all those recommendations, the 10 set out in the report itself and in the summary. Everyone content with that? Good. Thank you very much indeed, Karen, Joe, others. Thank you again for your work on this. That brings us to item 10, the primary care recovery plan. And can I hand over at this point to Mark Burgess and Sadie Parker?
Thank you very much, Patricia. And I'll be very brief before handing over to Sadie, who is far more versed on all of the detail and does all the hard work. So as highlighted in the paper, we are absolutely making progress, but just like to acknowledge there's still much work to do in terms of supporting general practice, specifically in primary care in more general terms. Real pressure, resilience concerns, and are thankful to and want to really continue working with clinicians and also the LMC to really make the improvements that we need to in these areas. We are absolutely committed as an ICB to supporting primary care. It's indeed one of our stated priorities. So, but I think it's important to acknowledge the pressures that our colleagues face in primary care at the moment, as in many other areas of the health system. The final point I wanted to just make before I hand over to Sadie is that acknowledging that pressure that we see, we also, our team as an ICB is experiencing that pressure. So my thanks, putting on record my thanks to Sadie and her team, who work valiantly to try and support colleagues across primary care. And we have indeed, in fact, put new posts in our structure to try and support this work, because it's so important for us as an ICB and as a system. So I'll hand over to you at that point, Sadie.
Thank you very much. Hello, everybody. I'll take the paper as read. As Mark has mentioned, this is part of the National Recovery Plan, and all ICBs are required to support general practice in this work and indeed report progress to their boards. The key commitments that we made for 23-24 are set out in Appendix B and Appendix A, along with our updates, and the key requirements for us for 24-25, the current financial year, is set out in Appendix C. I think, as Mark said, it has been very challenging this year, progressing the work, but there have been quite a number of successes as well. So Pharmacy First is an area where we've been able to make some really good progress since its launch in January, and we have all but 3 of our community pharmacies in Norfolk and Waveney signed up to this. They can focus on the 7 common conditions set out in the the paper, and whilst we acknowledge it is a voluntary service for community pharmacy, it's not part of their core contract, it does have great potential to support patients, patient care and wider access to primary care. So it is a key focus of our plan going forward. The digital elements included in your paper also provide a little bit of a view over the great amount of work that our digital team is doing to support developments in this area. So cloud-based telephony has been a major push nationally, and we've been able to build on the work that our team had already undertaken with piloting that with about a third of our practices. And we're making great progress with sign-ups to the NHS app to try and support patients to self-manage some of those things where possible digitally, rather than needing to contact the practice by phone, for example. The interface work, this has been a really key area of focus for us under Frankie's leadership. And I think we've had fantastic engagement from the system. We've got a strong infrastructure in place, and all of our trusts have undertaken the self-assessment tool and action planning, which is not common to all areas. So that's been good. Progress has been slower than we might have liked in some of the interface areas. And we understand that's due to many competing pressures across the system. But we in the work that we're doing, we are actually going beyond what is set out in the National Recovery Plan. And we have a number of task and finish groups set up to do that. Mark's mentioned about the resilience of general practice, and obviously you have a risk in your board assurance framework on that, which provides some of the latest updates. But I think it is really important to note that the BMA have gone out to ballot on industrial action for general practice, and we'll know the outcome of that at the end of July. So the potential for industrial action should be noted in our system. We expect that to have an impact on things like interface issues, and we're modelling that at the moment, which will of course have an impact on system partners. And just for context, our practices undertake about 6,000 appointments every day, and about 20% of the workload of general practice is estimated to be on interface issues. So it is really important that we continue to focus on this area. Thank you. You're muted, Patricia.
My apologies. Sadie, thank you very much indeed, not just for the presentation and the paper, but for all the work that you and your colleagues are doing on this, because this board over this board and its predecessors, but this board in particular, both in public and in private, I think, has really appreciated and tried to express our appreciation to our GP and primary care colleagues, because it is quite extraordinary the increase in the amount of work that GP-led primary care, or GPs and primary care colleagues, are doing, seeing far more patients, doing far more appointments than they were before COVID, often coping with patients who are much more sick than they were before COVID. Actually, that level of appointments that you just mentioned, Sadie, now I think equivalent to, on average, 1 appointment a month for half the population of Norfolk and Waveney. And this is a quite extraordinary level of demand. And on top of that, of course, the vaccination programs. So although there is a debate about productivity in the NHS, it actually is based on data and issues in the acute sector. The productivity in primary care has gone up very, very significantly with that demand, but also with largely flat funding. So a very difficult situation, and as you say, one that sadly has led the BMA to undertake this ballot in relation to industrial action. But I wanted, before we open up to discussion, I do want to ask Naomi Woodhouse, who's joined the meeting as the Chief Executive of the local medical committee, which I think, as colleagues know, is the statutory voice for GP-led primary care. Naomi, are there any comments you would like to make at this stage of the this item?
Oh, thank you ever so much, Patricia. And I'd just like to extend my thanks to Sadie and the team, because I know this is something you've worked really hard on and we've had many conversations on. And actually, it's really heartening to hear the acknowledgement from the ICB of the pressure that general practice is under. And I think it really cannot be underestimated, the pressure general practice is facing and the worrying outcomes that could come of that not being fully supported as a system to keep general practice stable. Now, we appreciate some of this is all national and outside of the ICB's control, and disappointingly, that is what has now led to the action that the BMA is proposing, and it's a really sorry state of affairs that this is seemingly the only option. However, it evidences just how much pressure general practice is under. And certainly the feedback that we get from practices is that it's workforce, workload and funding that are the main constraints. And one of the biggest one of those are the interface issues. And we acknowledge from the report about the amount of PIDs that are submitted. And I think we all agree this is not a fair representation of actually the workload that general practice is facing, and largely this disengagement is due to the workload involved completing the PIDs and the slow progress in interface work to overcome these issues. But that is having a knock-on effect, and unfortunately that work is at the expense of the core contract, which is what we really need to prevent being destabilised and support. And I think just final comments being, we have started a GPAS report, which is akin to the OPAL system that hospitals use. And from that, it is evidencing as much as you can put an equivalent measure on general practice as you can secondary care, it is evidencing that the real pressures practices are facing and the real need for the ICB to make sure it is implementing its priority for general practice as one of its top priorities. Because if the bedrock of general practice that is running at the moment is destabilised, that will impact the whole system. So it really must be a priority in every area that the ICB is able to influence and develop on solutions for.
Thank you very much indeed, Naomi, and really helpful and insightful comments. Let's now open this up to the board. Frankie, let me come to you.
Thank you, Patricia. Yes, I think we are all reeling a little bit, I think, by the scale of the workload provided by primary care. And I just wanted to acknowledge the very regular contact, a very close working relationship that we have with the LMC, trying to work together to do all that we can to find ways to support primary care and to acknowledge just the tremendous reliance we have on them. So just Naomi mentioned workforce, workload and funding. I'll pick up on that workload piece. We are rightly very concerned about patients in crisis, people who have urgent emergency care needs. But of the 660,000 appointments delivered in primary care last month, 57% were either on the day or the next day. So a huge proportion, probably about 80% of all our urgent and emergency contacts are actually with general practice rather than the big white buildings at our three sites. So I just think it's really, really important that we acknowledge that. And 77% of all appointments in general practice in Norfolk and Waveney are face-to-face. It's just I think really worth acknowledging those huge numbers. That
is significantly higher than the national average, isn't it?
It is.
I think.
Yes.
Yeah. Okay. Thank you very much, Frankie. Right. Other comments or questions from colleagues? you know, these are issues we've discussed in the past in the board, and I think the you know, the strength really of the plan and the commitment in it from the board and from the senior executive team, I think is very visible to everybody. So thank you. On that basis, I think we can endorse that strategy. And Sadie, Mark, colleagues, thank you very much indeed for the work. Right, now that brings us to finances. So really important and obviously directly related to all the performance, quality and safety issues that we have been discussing. So Stephen, can I come to you both for items 11 and 12, so month 11, but crucially the 24-25 plan.
Sure, thank you very much, Chair. So I'll take us through month 11 first. So these are the financial report to the end of February, whilst we go through the final month of the financial year, which will then go to our Finance Committee before being presented to board. So month 11, we reported a break-even position, and our forecast for the ICB is a forecast outcome of a break-even as well. You may recall from earlier reports we were seeking 17 million or further efficiencies to bridge our financial gap to get to break-even. Pleased to report that we found 17.8 million of pipeline efficiencies which we progressed, and we're on track to deliver that to get us to the break-even. In terms of cost pressures this year that have been really challenging to manage, in particular, continuing healthcare, we've seen a 19.4 million cost pressure, which is above inflationary funded levels. So that's been a real challenge this year to manage and continues to be so. And also 8.2 million of prescribing pressure as well that we've been trying to manage and mitigate. Also acute pressures of 14.9 million, particularly towards the end of the year. We've been trying to fund some waiting list initiatives to reduce down lengths of waiting lists. The main issue, of course, that we are trying to keep track of as we move out of the year end and into next financial year is the underlying deficit within the ICB. That's currently at 102.3 million. It's a very, very small reduction from previous years. What's driving that? Mainly, as I've said earlier, CHC, so continuing healthcare pressures in particular. Also, lots of efficiencies we've been successful in finding over the previous years have been non-recurrent in nature. So we're having to find them year on year rather than making recurrent efficiencies that help us keep on a sustainable footing. We've also got a large level of risk, which we've been trying to manage and mitigate throughout the financial year. So that at the start of the year was at 75 million. We've managed to mitigate that down throughout the year, down to around 2.5 million, which we are trying to manage through to the year end clearly. So that's a really positive position. The biggest risks that we've got and the risk register that you can see, section 2 of the paper, by far the biggest one is what I've just described, which is the underlying deficit, which we are looking to manage down and get into a much more sustainable position. CHC, obviously another red risk on the register. But we've also included in there the reorganisation. So as you know, the running costs of ICBs over 2 years need to reduce by 30%. Whilst we are well into delivering against that target, clearly we have to manage that over the year end and into next year as well. So we've still recorded that as a risk register and will continue to work to mitigate away the risks that we have around that. So I'll pause there for item 11, which is the month 11 report, and happy to take any questions on that before I move on to planning.
Thank you, Stephen. Any questions from colleagues? No, I think that's very clear and pretty familiar territory by now, I think, Stephen. So yeah, move on to the planning, please, for the current year.
Okay, thank you. So as Tracy mentioned earlier, the planning for next financial year hasn't quite concluded. It's been rumbling away for some time. what we've got is a position where on the 2nd of May we submitted our kind of our latest final draft of the plan across the system, including the ICB's results. What we submitted was a 36 million deficit. Now that does include 5.5 million of accounting changes at the NNN around their PFI. So if we were reporting in the same way we had previously, they would be at break even, but because of changes in the accounting rules, that means there's a 5.5 million deficit, which adds up to a 36 million deficit across the system. And I want to say, when I say system, I just mean the NHS providers and the ICB within our system in terms of this report. Also, again, we have a large underlying deficit across the system. So I described just over 100 million the ICB. When we include all providers across NHS providers across our system, that totals 228.4 million underlying deficit. So we are aware of the challenge and are seeking to implement things which will help us to reduce that down as soon as possible. Tracy's already alluded to this, so we've got a real challenge in our efficiencies this year, which I think the NHS is seeing right across the country. So we've got 6.1%, which equates to 176 million of efficiencies within the plan. At the moment, we've got around 75% of that figure is recurrent and 76% is identified. So good progress on that, but still some way to go to fully identify our efficiency plans to get to that 36 million deficit figure. We have a net risk of 115.8 million that we're reporting as well. That risk figure was over 200 million, but we've mitigated some of that away through our planning process down to 115.8 million. Most of that risk really sits around non-delivery of efficiencies. So some of our efficiencies might appear high risk at the moment. So they've been included in our risks. Also, we've included in there as well some of the things around whether we may need to open additional capacity through winter and some of those kind of things we've seen in previous years. So we've got those in a risk, and we'll look to mitigate those down as we work through the year. We also have a triple lock in place. So this is something that was around last year, but has changed slightly as we move forward. Because we have a deficit plan, NHS England operates something called the triple lock. So it's rather a complex process, but put simply, we have to have all of our expenditure, both pay and non-pay, challenged firstly by the ICB through an investment panel, and then any approvals we make through that, and then finally approved by NHS England before we can commit to the spend. Slightly different arrangements depending on the size of your organisation, but quite low thresholds in terms of the kind of expenditure we have to push through this process. In terms of numbers of what we're submitting at this point in time, we have James Paget have submitted a 17.9 million deficit position, the NNN with a 5.5 million deficit as described, Queen Elizabeth 14.1 million deficit. Both NSFT and the ICB have break-even plans, and NCH&C have a 1.5 million surplus. It's around a 62.9 million improvement from where we were at our draft submission back in March. So we've made some significant progress in trying to work towards break-even, but clearly not quite there yet. The drivers of our deficit that we describe it over that 200 million mark and are featuring as real problems for us in trying to get to break even this year, some of which I've mentioned in the previous report. So over 40% of our underlying deficit is linked to CHC. We've also got unfunded capacity in some of our acutes because of pressures around discharge, etc. They account for around 10% of our underlying deficit. We've also got things like diagnostic and elective recovery. Some of the funding that supports that is non-recurrent as far as we can see at the moment in time through guidance, and that accounts for around 20% of our underlying deficit. Other areas that contribute to that are things like out-of-area placements, particularly through our mental health trust, which they are working to address. Final thing I think just to say is our capital programme. is around 80.7 million. We earned 2.8 million additional capital for working towards a break-even position in the financial year that has just closed, and we've allocated that across the system, and we have a fully worked up plan to deliver against that capital funding, as well as significant amounts of central capital funding that support diagnostic assessment centres, community diagnostic centres, and other programmes that we have within the system this year. Now, the reason planning hasn't closed is because we have been challenged collectively across the NHS, not just in Norfolk and Waveney, but the total of the plans submitted on the 2nd of May were unaffordable. That's meant that NHSE have worked right across all the systems in the country to set targets where systems aren't at break even, and that's generally a reduction in the size of the deficit that you are working towards. So we received our target just over a week ago, and that means that we've got to go from 36 million to 30 million, so a 6 million improvement, and we will anticipate submitting that plan probably mid-June, as Tracy described earlier. We're currently working through options and ideas with providers and through the ICB themselves as to how we can deliver against that. We're using a financial recovery board that we set up just over a month ago, with all system partners involved to really chase some of the difficult things that we may need to do, but will deliver efficiencies for our system, whilst ensuring that we are mindful of quality, safety, and patience as we work through those efficiencies to deliver on the finances. So I'll hold there, happy to take any questions.
Thank you, Stephen. Again, a really clear presentation, but thank you and your team and Andrew Palmer and others for the enormous amount of work that is going into this very difficult process in the current financial climate that we're all aware of. Questions or comments to Stephen? I think that was so comprehensive. I think probably Caroline.
I was just going to thank Stephen for such a comprehensive update and setting out the issues so clearly, and we might talk about it in the next BAF discussion. But the significant risk that there is even to achieving the current plan is you can't underestimate that. I think across all of our organisations. I just emphasise that. Thank you.
Thank you. We'll be coming shortly to a report, of course, from Finance Committee as well. So I think at this point, Stephen, thank you very much indeed for the presentations, the papers, and above all the work on this. Right, that brings us to item 13 and the board assurance framework. Karen, over to you for this.
Thank you. We've got the papers here, the usual board assurance framework. We have a covering paper that highlights the changes since the last board. We also have a copy of the board assurance framework for you to review. Just to say, we are doing some work on this as an ICB to relook at how we manage and work through risk as an organisation. So I'm hopeful of bringing a paper back to board in July, basically proposing this works in a slightly different way. But for now, we have the usual risks that have been reviewed by the executive management team and by directors, and they're here on any specific questions. So it's over to the board really for any comments, questions. Thank you.
Great. Thank you, Karen. Questions or comments from the board? Hein.
Yeah, thanks, Karen. I think we should record as a board the potential risk around general practice resilience in view of potential industrial action. Because the next time we meet, we maybe know what's ahead of us. So I just think it's good for all of us to acknowledge that. That was my point. Thank you.
Yeah, thank you very much. Caroline, That's a fresh hand, is it, rather than a
It
legacy
is.
hand?
It
Yeah,
is.
no, that's fine.
It is, please. Thank you ever so much, Chair. Recognising Karen's point about refreshing the BAF, but from Stephen's presentation and the conversation we've just had, I wonder if the financial risk needs to be higher. But I can see that currently it's retrospective in terms of achieving the end of year plan rather than the current risk that we've got.
Perspective.
Yeah, yeah.
Mm-hmm.
Thank you.
Okay. David, I'm just wondering, assuming you've joined us, sorry, because I haven't got a...
No, yep. I'm here.
Right, thank you, David. I just wondered whether you wanted to add anything, particularly in view of those two comments about...
Yeah, no, and I think those are very valid comments. I think it reiterates the point of keeping the risk register up to date, because this is on a look forward basis rather than a risk that has already transpired and passed. I think the only thing I'd say, which I say most of our meetings now, is that I think as a board we just need to note the number of risks that sit down in that bottom right hand corner, in the sort of high probability, high impact area, which I think accurately reflects some of the discussions we've been having as a board, and demonstrates, I think, just the importance of managing those risks and keeping an eye on the mitigating actions we're taking against them, because the more we have in there, patently the greater the probability that one of them will materialize. But I think it's worth just making sure that as a board we've noted that we are operating in an ever increasingly risky environment.
Yeah, and I think this is a theme, across the entire country and all systems. But sitting alongside more patients, and often much sicker patients, actually receiving care day in, day out. So you've got all those risks, but also some, exceptional examples of outstanding care, and also it completely underlines the conversation we have regularly at the board about the need for transforming our model of care and using digital tools and all the rest of it to actually improve the quality and safety of what we do and reduce the risk. But thank you for all of those comments. Karen, are you happy with those? Do you want to add any response?
No, that's fine. I think Emma's got a hand up there.
Oh, apologies. It didn't show up on my system. Emma.
Thank you. Karen, I don't know if it's appropriate or helpful at all, but I can see that the VCSE is mentioned in some of those risk areas, but I can foresee a time when there might need to be a specific risk just about the voluntary sector who are being impacted by some of the cost of living issues. And we have got some large organisations that are closing or at risk of closing, nothing to do with ICS or ICB funding, but for external stuff. And I'm just wondering whether we need to just keep an eye on that somewhere, because it might impact on some of the work that we have aspirations to do as an ICB. And I can see us in there in separate bits, but whether we need at some point to think about what does that look like as a whole system.
Thank you. Karen, if you just hold that one. Thank you, Emma, and let me come to Bill, and then I'll come back to Karen.
Thank you, Patricia. I don't want to add another risk, but I just wanted to reflect on the points that I think have been coming up, which is the risk of us not proceeding at pace.
Exactly.
Given the acknowledged stress within the system, that sometimes it isn't flagged up, I think, as importantly as it should when we are looking at transformation. But actually, I think pace is already very important, will only get more important. I just wanted to reflect on that as we're talking in this area.
Really, really important, but perhaps also reinforcing that and reinforcing Emma's point, the fact that every sector, including local government and the voluntary sector and social care, are all under intense financial pressure, as is every other part of the statutory sector and much of the private sector. And so that both reinforces the need for transformation faster than we have managed in the past, but also adds to the risk of a crucial partner simply collapsing or being unable to do as much as they had committed to do. And that very much needs to be part of the way we manage our risks, just as we would, you know, or just as a hospital trust would if one of their key suppliers was themselves at risk of going under. So Karen, back to you.
Yeah, thank you. I was just going to make a comment on the VCSE. As you've said there, Patricia, there are numerous risks and issues, almost endless list. But we are going to be reviewing, as I said earlier, the whole of the risk management system as an ENT. So we'll take that on board, your comment there, when we're doing that review. So thank you all for your comments.
Good, thank you. So I think as a board we can note the current risk register, but obviously ask for those various comments and suggestions to be taken on board in the next stage of the work on this. Thank you. And we now come to our committee reports. Now, I'll take them in the order in which they are on the agenda. So the Quality and Safety Committee, Aliona, of course, has had to send apologies because of illness. Hein? No, who's reporting on this committee?
Would you like me?
Discussed it, but I think Karen Watts would probably be best placed.
Karen, thank you, if you wouldn't mind.
I'm on mute, so you can't hear me. So just bear with me while I pull it up. So I won't go through the paper line by line. It's very detailed, and you know what our statutory requirements are, and the arrangements we have in place for safeguarding adults and children, IP&C, meds optimization, etc., and diversity. So the last couple of meetings, we very much focused, and we were pleased to share at the last meeting our quality strategy and oversight dashboard, which is in its early stages, because without good data, you know, it's very hard to look at and to benchmark across the system what we're doing. So really pleased with the work we've done around our digital team and business and BI team. I mentioned before the CYP neurodevelopmental service provision. We also had a detailed conversation about the partnership agreement around right care, right place. And very importantly, and I've got Caroline on the call here today with me in the meeting, we had a really detailed update on the mortality action plan, and we're really pleased with the progress and congratulate the organisation in the size of volume of work that they're undertaking, because it's really important and it matters to people that have been affected. The David Fuller inquiry, which relates to a hospital away from our area around the arrangements around the mortality, the care of the deceased, is very detailed, and what we looked at as a system is all our plans in place, and we are reassured, and we're undertaking a series of assurance visits at the moment, and we'll be bringing that back to committee at a later date. Ambulance response times in relation to any potential harms and times to conveying patients is always important and received at committee frequently, and we also discussed the reasonable adjustment digital flag. So our risks are cited here, which also relate to our BAF, and I'm very happy to take any questions in relation to the paper on behalf of Aliona.
Karen, thank you very much indeed for stepping in so unexpectedly. Any questions or comments on the Quality and Safety Committee? Thank you. We can note and receive that report. Hein, Finance, please.
Yeah, thank you, Patricia. I think Stephen already covered a lot. I think to Caroline's earlier point, we have a finance committee next week, so we will definitely look at risks to the 24-25 plan. I think the two things I would like to lift out is I think this is a strategic concern around the underlying deficit. As NHS organisations in Norfolk and Waveney, we spend roughly £2,400 million every year. So 200 million is not just in absolute terms a big number, but also relatively speaking, so a big strategic ask. And it was good to hear, and we'll hear more next week in the Finance Committee, the Financial Recovery Board taking shape to try and address going after that underlying deficit. That's all I wanted to say, given what Stephen has covered before.
Thank you, Hein. Any comments or questions to Hein? No, thank you. We can again note and accept that report. Thank you. Who could give us a quick overview or answer questions on primary care?
I can do that.
Hein, thank you.
So Debbie chaired, but she's not here today. But we had an extraordinary primary care commissioning committee early this month with two important topics. One was an application by Holton Medical Practice to close their branch surgery in Blakeney, decision deferred from February, because public engagement was taken by the Integrated Care Board. So in our meeting this month, we had the benefit of that public involvement. We had proper assurance that the due process was followed to reach the application request. And the committee approved the recommendation made by ICB management to approve the closure of the branch surgery in Blakeney, with a request to ensure there will be a local medicines collection service. And I think it's important as a committee, we acknowledge the efforts put into this process, both by the whole medical practice and the local community and stakeholders, and may I say also Integrated Care Board staff. The second item was the approval of the long-term dental plan. Tracy and Bill already talked to that. It's a really important milestone, building on the short-term plan approved last September. Also great to see that more than 2,000 people responded to a survey, which was overwhelmingly in support of the priorities that were identified. And the long-term plan has already £7 million of investments this financial year in a range of areas. That's all I wanted to cover on
Good.
Hein,
thank you. And just in relation to Holt Medical Practice, can I add to those you've thanked our colleagues at Health Watch, both Health Watchers who were really, played an important part in ensuring that there really was some very thorough public engagement and involvement. And Judith, I think you're still with us from Health Watch at this meeting, so many thanks to you and your colleagues for that, as well, of course, as the other work you do. Any questions or comments to Hein on that report? Okay, thank you. So we can note that one. Right, sorry, this is where I'm afraid today's absence was rather shows. So the Commissioning and Performance Committee.
I'll do that.
Hein, you're doing that one as well, aren't you? I'm afraid we're overworking you today.
I chaired this one, which was the first one in the new setup. I think that's important to note. So it's not just an assurance committee, but under delegation from the board, it's able to make decisions going forward. As it was the first meeting, we covered modus operandi, reviewed terms of reference, and then at the next board meeting, you'll see a somewhat updated terms of reference coming to board for approval. You can, I assume you've read the report, but I think there's a nice example around the 5 eye care specifications which have been developed in response to an accreditation request from an independent service provider. And there's the kind of examples that will come in the future to this committee for decision making. So I just wanted to highlight that one. I'll leave it at that. Happy to take any questions.
Fine, thank you. Any questions or comments on our new committee? Thank you. We can note that report. Patients and communities. Mark, you're going to,
yes,
I think,
happy to
cover that one for us.
Yes, no problem. Thank you. So a really good committee meeting last month. A couple of areas, I'll take the paper as read as always, but a couple of areas I would like to highlight. Again, you've mentioned Health Watch. I was about to too. We spent quite a bit of time in the committee focused in a bit of what we'd call a deep dive in the Great Yarmouth and Waveney area, where actually we look to triangulate a lot of the data, Health Watch, our data, public health data, to really bring partners in to focus on what more have we learned by looking at it in that collective sense, and actually quite a few actions and recommendations came as a result of that. So that was a really good piece of work, and thanks to Healthwatch, who actively participated in that. The complaints, we spent a bit of time looking at complaints and reviewing the complaints that were coming in, and also our response as an ICB, how quickly we are, how quick we are responding to those, and we have seen improvement in the response time. So our thanks went to the complaints teams, and importantly, we were then focused on the so what challenge. Yeah. So and focusing on how that information flows to the teams and to provider colleagues, and taking steps to try and address some of those issues that were raised. And that primary care we've been talking about today, linked to those pressures, that was one of the areas we focused on during that session. And then finally, just to highlight, in our committee meetings now, we're taking a place by place focus at each of the committee meetings, and inviting place boards to come and present some of the work that they're doing. And that seems to be just yesterday, Monday, we had our last meeting, and the North Norfolk Place board came and presented. That's proving to be a really useful session to really get under the skin of some of that great work that's happening at place and partnership level. So we will continue to report back here as that work continues.
Good. Mark, thank you very much. Any questions or comments to Mark? Right, thank you. And Cathy, over to you, please, for remuneration, people and culture.
It is a mouthful. So we did, of course, discuss the ongoing organisational programme and the developments there, but we also had a good discussion about the ICS workforce plan that was submitted on the 2nd of May, and the aim for a reduction in bank and agency staff. And what was pleasing about that is the greater collaboration across the acutes in the way they utilise bank staff. So there's real opportunity there. And that's all I would pull out from this month.
Fine. Okay. Questions or comments on that from colleagues? No. Thank you very much, as always, Cathy, for your work on that. Conflicts of interest, David.
Great. Thanks, Patricia. And we had our final end of year meeting back in March on this, really just to confirm that we have had no reported breaches of conflict of interest during the course of the year. But actually, when you look at the volume of discussion and questions that have taken place with the team, I think it demonstrates how seriously the organisation is taking conflicts of interest in what is a very complex environment, given the number of partners involved and the number of meetings and committees that are involved. So we were pleasantly assured by the level of inquiry that have been made of the team for various issues around conflicts. And other than that, really just to report that we do continue to have a very high level of compliance around conflicts of interest, the reporting of them, with 98% compliancy across the piece, which is extremely high.
Good. Excellent. Thank you very much indeed, David. I notice Audit and Risk Committee isn't on the list. Is there anything you want to add? Oh, sorry, we have a... Sorry, Karen, let me bring you in on...
no, that's fine. I was just going to explain why it's not on the list, but I'll let David speak first.
Ah, okay.
Oh, well, I hope I come up with the same explanation as you, Karen. Probably because it was very recent. Is that right?
Yes, that's the right answer.
Okay, yeah. Right. So sparing my blushes, it was very recent. I think the pertinent thing to raise is that we're patently into year-end mode now, and there'll be much more to report as our recommendations for approval of accounts, etc., come through board. I think the only other point I'd make is that we did have a deep dive on CHC with Tricia
Continuing
Dorsey.
healthcare. Yep.
Yes. And so really just to give assurance to the board that we continue to undertake deep dives onto some of the key strategic risks that we have as an organisation. And that is in spite of, or despite of, the fact that we do have a fairly heavy work programme sort of around year end, and gave you an assurance around that. But
Good.
you will get a more fulsome report the next time round when we come through with the accounts.
Good. Thank you very much indeed, David. Now that brings us to questions from the public. We certainly didn't have any notified in advance. Karen.
Yes, I've checked the system. We haven't had any notified during the meeting either. So it would just be if anyone here would like to raise a question.
Right. Thank you on that. And I take it we haven't had any coming in on the emails. So right. So that brings us ahead of time, almost to the end of the meeting. Is there any other business that anyone wishes to raise? No? Well, can I thank you all very much indeed for your attendance, and everybody who has attended either as part of the presentation or to observe the meeting. Thank you very much indeed for joining us. For board members, of course, we have a part 2 meeting due at 3:45, but in view of the fact that this meeting is finishing early, would you be happy to start the part 2 meeting at 3:30? Could we manage that? Thank you. It would be very helpful, I think, to several of us. So thank you. That concludes this meeting of the board in public, and I look forward to seeing board colleagues for the part 2 meeting at 3:30. Thank you all very much indeed.